Hello everybody, welcome. We're just waiting for everybody to come in. Feel free to start saying hello in the chat, where you're from and who you are. We'd love to hear from you. Just give it a few more minutes. Okay, wow, we're up to 44 of you, so hi, welcome. For those of you who just missed the first time, please do say hello in the chat. As we go through the webinar, ask any questions for the speakers in the Q&A at the bottom there as well. And we'd love to hear from you. Hi there, Lynn. Okay, hi and welcome to our second Health and Social Care Cluster Showcase event in partnership with CGI. I'm Emma Whitenstall, I'm the Cluster Engagement Manager for Dynamo. For those of you who don't know about Dynamo, we are a not-for-profit tech network with the core mission to grow the Northeast tech economy through collaboration, innovation and skills. So we're part funded by the Innovation SuperNetwork through their ERDF program and through our growing membership. So we work in clusters to support our members, and last year we witnessed increasing interest and really exciting work happening in the region in health and social care technology. So we joined forces with Dynamo member CGI, who are a global IT business services consultancy, to form this cluster. So we act as an industry working group feeding into a strategic steering group formed by the local enterprise partnership. And we work alongside partners such as the Nhs Business Services Authority, the Academic Health Science Network, the National Innovation Centres for Data for Aging, Proto, who do immersive tech, and all of those good folks doing exciting things in this area. So our aim of the cluster is to support organisations in the Northeast to improve patient outcomes, to showcase what the region has to offer, and work collaboratively to tackle the primary pressures faced by health and social care. So today's event is focusing on patient experience. It's going to present the findings of our first ever research project on patient experience. And we are welcoming some excellent speakers for you this morning from the field of health and social care to share their experiences and join in the debate. So we are short on time, so without further ado, I'm going to hand straight over to Tom Adams. He is a health and social care expert from CGI, but he's also going to talk from the patient perspective about why all this is important. So Tom, over to you.
So hopefully you can see and hear me. So good morning, everybody. My name's Tom Adams. I'm what's called a solution architect for CGI, but my whole career has been spent working in health and social care IT, including quite a long stint as a manager in the NHS. And more recently, I've been looking at really overall solutions to support integrated health and social care, including how we can use technology to support not only patients and service users, but the wider circle of care, all based around a prevention and early intervention agenda, as well as supporting people with long-term conditions. So I'm going to share a few slides with you this morning. And we're going to really start off with looking at what patient experience means. So what do we mean by patient experience? Well, this is really the whole process of understanding what receiving care feels like for the patient, their family and carers. And it's important to note this is a really important element of quality alongside providing patient clinical standards and safer care. So why is it important? Well, we can look at the individual aspects of this, and the real point of this is that understanding a patient's experience and the whole background to that patient can help to inform their patient pathway and ultimately deliver better outcomes for the patient. And when you look at that collectively, that can also inform, on the basis of patient stories and patient experience, the whole wider health planning and the design of models of care. Thirdly, and this is again a really important aspect, we can really see the link between staff experience and patient experience in terms of fulfillment and satisfaction. And obviously, staff who are enjoying their work, who are engaging with patients in a caring way, obviously feel better about their job and are delivering better and safer care. But I think it's important to note that we'll all be engaged in the system at some point in our lives, whether that's experiencing care as a patient or looking after members of our family or loved ones. And last but not least, the whole patient experience agenda is really thinking about the wider circle of care. So looking at unpaid carers, looking at the third sector, and how those different agencies can be involved in a whole patient journey through receiving care in the NHS, to being supported through the local authority, and helping people to live independent lives for as long as possible at home. Now, obviously, patient experience in the here and now is suffering quite massively from impacts of the pandemic. So we can see in terms of things like the PPE barrier, so not being able to engage with people, see their faces when receiving acute care, not being able to go and visit GPs for family and friends, not being able to visit people in care homes. And all of these things have had really quite a deleterious impact on patient well-being, but also on staff well-being, because they haven't been able to do the traditional models of care that they've been perhaps used to. And we can see that the impact of this is going to be massive in terms of future demand on services as well. We're seeing quite a big explosion in terms of mental health and well-being problems. We're seeing aspects around social isolation. We're seeing issues with anxiety around perhaps losing jobs or financial insecurity. And also the general worrying about people who are shielding out there in the community because they're already suffering from long-term conditions. And this is also disrupting some of the established care pathways, whether that's routine screening of people. We're seeing waiting lists going up. And of course, that's producing a backlog in terms of demand for services. So even though we're in the middle of quite a difficult period for staff working across health and social care, this isn't going to go away quickly, because there's going to be a big backlog of work to cope with going forwards. It's important to note that patient experience is not really a very new concept. It's embodied within the NHS Constitution, which was rewritten in 2011. So this whole concept that the patient will be at the heart of everything that the NHS does, and was also referenced in the white paper of 2010, which was when the phrase "no decision about me without me" was first embodied in terms of NHS policy. And then we've seen other different initiatives within the NHS, the Patient Experience Framework, the Patient Experience Book, the NHS Outcomes Framework, all sorts of different initiatives which really have at the heart aspects of really baking in the patient experience in terms of everything that the NHS and indeed social care should do. And then more recently, particularly in Scotland, there's a real focus on what's being called realistic medicine, which again is looking at the whole background of people and putting that at the centre of planning care services for people across health and social care. And obviously specific initiatives such as PALS and PROMS, so patient advice and liaison services and patient reported outcome measures, and also some more facilities that have been introduced, such as NHS 111 and NHS 24 in Scotland. But I think at this point it's worth quoting from Derek Feely, who's just produced an independent review of adult social care in Scotland, which came out in February. And I'll just quote from the introduction of that, which in relation to all of this policy stuff says, "There is a gap, sometimes a chasm, between the well-intentioned groundbreaking legislation and the lived experience of people who need support." So food for thought in terms of where we are with patient experience. So The reality in terms of patient stories, and patient stories are a really good way of understanding patient experience, relates to a range of different issues across accessing health and social care. So we all know the issues around trying to book a GP appointment, hanging on the phone at 8:30 in the morning. Not really ideal in terms of a flexible and responsive service. Often the language used in the service is a barrier to patients and service users. Aftercare, reablement and continuing independence. Again, this is really the focus of what people are trying to do in integrating NHS and social care services. And common experiences that we hear about is patients having to tell their story repeatedly to every single individual that they come in contact with as they're going through the service. And at this point, it's probably worth giving you a couple of stories from my own experience just to bring this to life. So the first relates to my mother, who passed away a couple of years ago. So she lived alone in Edinburgh. And we'd been concerned as a family, myself and my two brothers, that she was showing early signs of dementia. And it was really difficult to get access to services because the main diagnostic test was the infamous memory test. And she tended to do quite well at that. So we couldn't really engage the service in terms of helping to look after her. And it was really only at one of the social work assessments when my mother introduced me to the social worker as, this is my brother Andrew, who unfortunately is dead, that the penny finally dropped and we got the diagnosis and were able to engage care services. But even then, being two sons remote from my mother, getting access to information was really difficult. Everything was written down on bits of paper, so it involved having to phone carers to find out what was going on. Second story I'd like to tell you about is a more recent one. I have a brother who also lives in Edinburgh with some fairly serious long-term conditions. And on New Year's Day, he fell over and broke his arm and was admitted to the Edinburgh Royal Infirmary and spent the next 5 weeks there before being discharged to a rehab facility on the 8th of February. He's since tested positive for COVID, thankfully without any symptoms, but he's going to be there for the next 12 weeks. And as we understand, he's been diagnosed as having some capacity issues going forwards. Now, the problem here was that throughout that stay in hospital, we weren't able to talk to a doctor at any point in time, although obviously we were phoning the ward to talk to nurses, and we did talk to a social worker. And the only way I could really find out what had happened and what the diagnosis was and what the ongoing care package is was to phone my brother's GP practice. I then had to book an appointment to phone the GP. I then had to put in writing a request to see his discharge summary, and that eventually came through, and I was able to see what had actually happened to him in hospital and what the ongoing plan would be. So that kind of brings to life some of these issues in terms of patient stories. So what do patients say that they want to have going forwards? And there's been a lot of research done in this area, both in terms of the NHS and local authority organisations. So it's all about treating people as a person, not a number, understanding the whole background to that person, what they like, what they dislike, and building a treatment plan that helps people to help themselves, and that can be through accessing resources in the community, involving family members and the wider circle of care, using technology at home, and providing people with access to their records and the ability to record things about their condition going forwards. So lots of different things that people say that can help. And all of this has kind of been now embodied within some policy work that's going forwards. So people are probably familiar with the concept from a quality perspective of never events. So these are things that should never happen in terms of the delivery of healthcare. And this concept has now been extended into what's called always events. And this is really around understanding a patient's background, understanding what's happening to them throughout their journey through the service, and baking that into policy and practice. And the NHS has also embodied this whole approach in what they call the Nhs House of Care. So again, it's all around leadership and organisation, creating a culture which embodies patient experience in the work that organisations do, providing staff with the tools and support to carry this out in practice, getting continual feedback from patients about what's happening, analysing incidents, analysing complaints, but also feedback through proms and other survey mechanisms, and baking that into the design of services going forwards. So this is what we mean by experience-based design. And last but not least, something I've really been focusing on is the use of tools and technology. So we're seeing really an explosion in the capability of technology to help patients and service users going forwards. So that can be simple things like having online appointment booking. So making sure that appointments to see health and care professionals fits in with people's lives. We've already seen an explosion through the pandemic in the use of virtual healthcare solutions. So these can be virtual wards where people are monitored at home rather than physically in a hospital, but also the use of video conferencing to have client meetings with health and care professionals done remotely. We can look at electronic proms, we can look at a whole range of different things for technology-enabled care. So this can be the use of wearables, it can be the use of sensors in the home. So one thing that my mother experienced was wandering at night. So you can have sensors in the home to check whether somebody's opened the front door in the middle of the night, but also whether or not they've got out of bed or opened the fridge. Patient portals, again, lots of vendors are now offering these, and these give not only the patient or the service user, but the wider circle of care access to what's happening with the patient, so previous diagnoses, correspondence, etc. But it also provides a feedback mechanism for the patient to record how they're feeling, perhaps from a well-being perspective, but also recording measurements and different activities that have been kind of assigned to them as part of their care pathway. Signposting apps, again, this is really useful, and this helps to engage the wider set of resources that are available in the community. So things like Alzheimer's Scotland and similar organisations based in England, and also community groups that are more local to people that can also help with ongoing care and support. And last but not least, for the staff, obviously, when we're looking at integrated health and social care, we need to have much better technology and tools to support all the teams of working in the different organisations, whether it's general practice, the acute sector, community and mental health, and social care, to share information about people, obviously done with consent and in a secure way, so that those models of care can be managed, people can get access to the information they need, they can update care plans, etc., in a much more joined up way. So that's just really some food for thought in terms of what patient experience is, why it matters, and some of the tools and technologies available to help this going forwards.
Thanks so much, Tom. That was a fantastic introduction, and thank you for sharing your personal experience as well. That was great. So I'd like to hand over now to Annie Laverty. She is the Director of Patient Experience at Northumbria Healthcare NHS Foundation, and she is here to talk about her work in patient experience. Over to you, Annie.
Can you see that?
I can see you, but no slides yet.
Okay, forgive me. Hold on a second.
Yes, that's it.
Is that it?
Yeah, great. Thanks.
Okay, so good morning, everybody, and it's a real privilege to be part of the meeting today. I'm Nhs Laverty. I'm Chief Experience Officer with Northumbria Healthcare. I've been Director of Patient Experience with the Trust since 2009, but my role changed in 2018, recognising that inextricable link between staff experience and patient experience. So what we want, and huge thanks to Tom for just outlining that for us today, this morning, to start the event. But if what we want is high quality, safe and compassionate care for patients, we need that to be delivered by staff who themselves feel safe, competent, confident and able to provide the care that we'd want for all of our relatives. And Tom also mentioned the evidence base supporting patient experience, and the truth is it's been around for almost a decade now. We know that patient experience is not a pink and fluffy add-on. We should resist sidelining it as something that is too subjective or mood orientated and divorced from the real work of measuring clinical effectiveness and safety. Because it's absolutely clear from the evidence that organisations that engage and involve people who use their services in both the improvement and delivery of care will be safer as a result of that, and provide better quality services and services that are also more cost effective. So our focus has shifted as an organisation. Every year the national staff survey results are published, and there's a question that I go to first of all before I go to any of the others. And it's a question that we ask NHS colleagues: to what extent do you believe that the care of patients and service users is your organisation's top priority? And in my trust in 2007, only 43% of our staff believed that that was the case. That focus has changed for us as a trust, and in 2020 we scored 91%. So that leap over time in just over a decade, quite remarkable, and a reflection of a whole host of work that's gone on in the organisation, and patient experience and measuring and understanding and improving patient experience, just part of that. So I'm a clinician by background, care of older people, my specialty, and so really driven by data, really driven by evidence, and so we have a really strong focus on how we understand in our complex geography across multiple hospitals, from very rural areas on the borders of Scotland over to Hexham in the west and down to North Tyneside. How do we be confident that the quality of patient experience across all of our services and hospitals is the same? And so we talk about making toast with our data, and we've invested heavily in patient feedback. We have one of the largest and most extensive patient experience programs in the NHS. We listen and receive the views of more than 50,000 people every year. We do that in a variety of ways, and we do that in a variety of times because we know that that matters. So we have a program of real-time measurement, which involves 700 conversations every month face-to-face when people are with us in hospital, so that we can nimbly respond to what they're telling us and get those changes in place for them whilst they're with us. That's fed back to clinical teams within hours. But we also recognise the evidence tells us that it's actually 2 weeks after care, often when people have gone home, that they've been able to reflect on their whole experience with us. And statistically, that's actually when patients and clients and service users will be at their least happy, and more willing to tell us about the warts and all picture. So we deliberately target that 2 week point of care and after transfer out of hospital, to learn about our biggest improvement opportunities. We would recognise that some of the approaches to measuring patient experience aren't accessible by all, and having equality and diversity embedded in our engagement approach is really important to us as an organisation. So we've really welcomed the opportunity to work with third sector organisations. This was work that we did with people with learning disabilities to get a real understanding of what it was like to be sent an outpatient appointment, and how inclusive that process was, and how we could quite simply use photography to demystify and improve access, and also improve non-attendance for outpatients within the system. We've also worked with older people themselves as advocates for older people on our wards who have dementia and delirium, to visit our wards, witness in real time the communication and care that is occurring on those wards, and feedback to staff in real time about the opportunities we were taking to promote dignity and those that we were missing, so that we could do something about that. Our work plan on an annual basis will have inclusion at the heart, and some of the challenges around measurement is how do we make sure that we include all groups and communities in that, and particularly groups that are represented by protected characteristics. So we've needed to shift and adapt our methods and approach to measurement in order to make sure that that voice is heard. And we've needed to be more creative sometimes about the way that we improve and build trust in communities. So the examples that you've got on your screen there, award-winning work that we did with Syrian refugees, and an engagement work around building trust within those communities and improving access to healthcare by starting a football league on a Sunday where NHS staff could play football in local community centres and just build relationships as a way of starting that improvement work. Similarly, bush tucker trials with young people, a focus group by any other name, but if you want to talk about sexual health in a way that young people are willing, they're not necessarily going to respond to your email or your survey, but run a bush tucker trial around in a remote part of Northumberland, and you can engage people in different ways and capture really invaluable information and feedback. A real cornerstone to our improvement work, in my opinion, is transparency, our willingness to share all of the information that we get, put it on our walls, publish it, have it on our website. Even the stuff that we're not proud of is the fastest way, we believe, of improving and getting better. So across our services and our hospitals, you will see us update and regularly share information about all aspects of our service, including all free text comments received from families about care in the last month. This is work that we've done to integrate patient and staff experience. So in each of our hospitals, and updated every 3 months, is these posters that describe what it's like to receive care in this hospital if you're a patient here, versus what it's like to work in this hospital if you're a member of Northumbria staff. And again, really bringing those two things together to confirm that relationship between staff engagement and improvement, really resulting in better care. And the next few slides, really, I just want to flick through to show you how we've measured and start to learn and understand patient experience at a granular level in our organisation. So we can learn about how we do organisationally, and we can compare how we do with other NHS organisations. We've changed from an organisation that was ranked 111th in the country when we started this work to 10th last year, beaten only by single specialty organisations that don't have A&E departments. So that's great company to be keeping with, and that we want to stretch us in terms of the offer that we make to our local communities. Best inpatient results in the region for the last 3 years. And then we can drill down to a site level. So when we make big strategic changes in our organisation, like open the first emergency care hospital in the country, we were able to very quickly in that first year get real-time feedback from more than 1,300 patients and see the statistical changes that occurred as a result of making redesigning care for those that needed to access services in an emergency. And we've been able to track those changes over time and see the impact pre-opening NSEC and post-opening EXEC, but we can see that for all of our hospital sites. We're currently doing some work around Hexham to understand the impact during COVID. All of our ward teams every 2 weeks in real time will get updated information about what their patients think about their care based on evidence-based core domains. We measure about 10 factors, and they were all covered by the list that Tom shared on his slide. But teams can see how they've improved over time. We use statistical process control charts. This is really important for our team so that they can nimbly respond to what are meaningful improvements or deteriorations in care to ensure that we are as responsive as an organisation as we'd like to be. And if you're a consultant in my organisation, what your patients said about you last year gets compared with what your patients are saying about you this year and is fed through your appraisal. It's very transparently shared with the results of all of the other consultants within your specialty. And again, this is not sharing information in a punitive way or for judgment, but for improvement's sake. We're able to benchmark that against national data and provide teams and individuals with the support to provide better care. Tom mentioned the power of stories, and I'd wholeheartedly agree. We rely on storytelling a lot. Every board meeting begins with both a patient and staff experience story, and I've committed to ensuring that those stories aren't told unless we have an improvement program supporting that work. Because stories are told at a price to the storyteller, and we owe individuals the respect of doing something with the information that they so readily are willing to share with us in a very powerful way. Our real-time conversations, as I say, we speak to more than 700 people every month and have done that for almost a decade now, brings really rich stories that we can share with staff within hours, and it really engages the heart, the minds, and efforts behind improvement, as well as celebrating excellence when it deserves to be told. I promised the team I would come in time today, and I hope I've been able to do that by flicking through a lot of slides. But I wanted to share with you, my story today was just really around how we focus on measurement and the wealth of data that we now have as an organisation. What I'm excited about is the opportunity to work with technology to really understand through artificial intelligence if there's anything that we can glean from those stories, that measurement that we may be missing as an organisation as our approach through technology becomes more sophisticated. Because it can be, and I've worked in the NHS for 30 years now, it can be at times that you can feel that you're part of this colossal machine that will turn of its arbitrary rhythm, and yet the opportunity to stand back from that and that notion to promote the fact that human caring and the effort to do better for people can make a difference, can seem hopelessly naive, but all of our measurement and understanding and improvement over the last decade has convinced us that that is absolutely not the case. And the commitment of our organisation to doing this work in the way that we have has been more than rewarded. I think I'll stop there in the hope of sticking to time.
Thanks very much, Annie. That was absolutely excellent. We are going to move on to the same topic from a social care perspective now with Steph Downey. Steph is the Service Director of Adult Social Care at Gateshead Council. I will share your slides, 1 second. Steph, are you ready?
I think so. Can everybody hear me?
Yes.
Great, thank you. So hi everybody, as Emma said, I'm Steph Downey. I'm the Service Director of Adult Social Care at Gateshead Council. I'm here today predominantly in my role with Gateshead, but also worth noting that I do have some roles across the region. So for example, I chair the North East Association of Directors of Adult Social Services, or ADAS as we all know it, Great North Care Record Group. So I'm part of the work that's basically trying to get local authorities joined up to the Great North Care Record. So I have some regional insight as well. And I think it's fair to say that adult social care and councils probably in general are in a very different position to our colleagues in the NHS, and hopefully that will come out from some of the information that I'm going to share today. So Emma, if you could move to the next slide, please. Thank you. So what I've focused on this slide is just really to give a little bit of oversight, and apologies, I believe there are some colleagues from other local authorities watching the webinar, so I apologise to you if I'm going through things obviously you already know, but conscious that there were people who probably don't know how we collect information within adult social care, and thinking particularly about how we can use artificial intelligence and technology to support us in understanding the experience of people who use our services. I thought a good starting point was to talk about the information that we already gather. So we are nationally required to undertake a number of surveys. We undertake on an annual basis, albeit we haven't for the last year because of the pandemic, an adult social care user survey. And then on a biannual basis, we undertake a carers survey. What I would say about those surveys is they are heavily prescripted by the Department of Health and Social Care. They ask a range of questions and they come up with weighted scores. And one of the challenges that we have as local authorities, and I should say I've worked in 3 local authorities in the North East now, so I can confirm that certainly my experience across all 3 local authorities has been the same, is that often the data that we get back from those surveys doesn't particularly help us. We know that the survey group is a different group of people every year, so there's questions around how representative the information is. We know that obviously some of the questions that people are asked don't necessarily reflect their experience of care, so they talk more generally about how people feel, around whether people are feeling safe, etc. So we're conscious that other things that are going on within the world and within people's communities can have an influence on how they respond to the survey. And we have very little opportunity to go back and to speak to people to try and clarify more information. So they give us trends, they tell us whether we're going in certain directions, but quite often they pose more questions than we have answers from the surveys. We're then required to collate a range of data and information in terms of our adult social care outcomes framework, and a whole host of data sets, again, similar to the NHS in terms of what's happened to people and how their care has been delivered. But what it doesn't predominantly tell us is how people have felt about it. So it tells us about outcomes, it tells us again about trends in terms of numbers of people being admitted to care, the number of adults with a learning disability and supported settled accommodation, the number of people in employment who have a learning disability. But what it doesn't tell us is whether those are good jobs, whether those people are finding the support that they get from the local authority to be positive or not. And then we also have things like our safeguarding return and our best interests return. And again, this measures how involved the person might have been within a process and whether their expectations were met. However, they're largely as the service has reported them. So making safeguarding personal, for example, is a really important part of our work in safeguarding, about how we work with individuals to make sure that when they're in the safeguarding process, they are directing that, they're able to set their outcomes, their expectations, and able to say what it is that they want to happen throughout the process. but the information is then all recorded by the social worker or the professional and doesn't really involve the voice of the person. And on that point, I would note that we've got a real difference within local authorities between adults and children's social care. And one of my reflections would be perhaps that the role that Ofsted plays in assessing and regulating children's social care does mean that there's a real importance in terms of being able to demonstrate the voice of the child and how that has influenced the work that's taken place within any child situation. And we don't really currently have an equivalent in adults, though, again, as many colleagues will know, the recent NHS white paper has indicated that that is about to change. So I'm expecting that we'll see quite a significant shift in adult social care if we're going to move into a framework again of regulation by CQC, which is what we had prior to 2010. If you could move on to the next slide, Emma, thank you. I do feel a bit like Chris Whitty, despite saying I wouldn't. In terms of what we do at a local level, so obviously I've covered the things that we are required to do nationally and some of the limitations of that. At the local level, obviously the way in which we collect service level data and feedback from people will vary from council to council, but I'm sure within this some degree of commonality across us all. So we will all work with our local voluntary sector partners, for example, to undertake experiential reviews. So in Gateshead, we have Healthwatch, who are a combined Healthwatch with Newcastle Healthwatch, and sometimes they look at undertaking a review of a specific topic. It's often fed through from things that people have reported on their Have Your Say website or surveys that they've undertaken. So recent ones have been about people's experience of carer services in Gateshead. There was a joint piece of work done across Newcastle and Gateshead on continuing healthcare. And in those scenarios, we as the local authority will respond to the survey that Healthwatch are undertaking. We'll provide information, we'll provide clarity, but they will directly speak to people who've had experience of that particular service area and undertake one-to-one interviews, surveys, focus groups, etc. Leading on to that, as I say, Healthwatch as an organisation do collate information on people's experiences of health and care services. However, one of the things I would note is that with the name being Healthwatch, I think a number of people don't necessarily recognise Healthwatch as being something that represents social care. So when you go onto the Healthwatch websites and look at the number of services that are referenced there, there's a much higher degree of reference to health services as opposed to social care services. But Healthwatch will absolutely try to reach out to people who use social care services, and they'll have their expert by experience panels, and again undertake a range of different surveys, sometimes on topics that we might flag with them. So for example, I would anticipate around the NHS white paper, we'll be asking Healthwatch to undertake some work to gather the views of people who use services in order to feed into our consultation and feedback on the white paper. We're currently certainly in Gateshead at the end of our budget setting process for this year. That information went to Cabinet yesterday, but alongside that we often undertake consultation exercises, so they may be specifically related to the budget, or it might be around redesign of a service. So clearly within our sort of role as a local authority, our transparency and our need to involve people who use services and our wider residents, we will go out and talk to the public about something that we're planning to do. We'll seek their views, we'll seek the input of people who currently use a service if we're going to redesign the offer. And those consultation exercises historically would have ran in person, so quite often in the likes of drafty church halls or civic buildings, but obviously over the last 12 months that's been predominantly done online and doing sort of Teams meetings, etc., or through online surveys. We seek particular feedback from people in relation to the interventions that we undertake. So for example, the intervention of our social workers in the assessments that they provide, and also the provision of care, whether that's care that we provide ourselves or care that we commission from other people. And on all of these areas, I think it's fair to say we're talking about unstructured data. So I know that was something that Mark Thomas had asked. Is this information that comes to us in a particular format, or are we often talking about free text information? We are, and as I'll cover on the next slide, quite often we're talking about paper-based information, so it's not even unstructured information in a digital format. It's often on bits of paper, letters. We have, for example, cards that we leave with people to ask them to fill in and return to say how they've found the experience of the intervention of the social worker or the assessor, and they physically come back into the office. The information is taken off those and collated and feeds into our compliments and complaints annual report. So the information is used, we take the information from complaints and make sure that we learn lessons from that. And that obviously is then disseminated across our wider services. But again, we're talking about information that predominantly comes to us in written format from our service users. I've talked a lot there about what it is that the council does. Obviously, as I mentioned before, we commission a range of providers. So our care providers are more likely to be trying to seek views from people in a TripAdvisor style. So we have a range of different websites that are available for people where they can rate their care home or their care provider. They can obviously then influence the market in terms of people's positive responses are more likely to result in more business for people, particularly if you're looking at services where somebody might actually be, specifically choosing, such as a care home. And it's an area that has been difficult and fraught, I think, as we know with TripAdvisor itself. Sometimes you're more likely to get a negative review from someone who's had a negative experience than you are to get a positive review from someone who's had a positive experience. And then word of mouth and recommendations. So we're really clear within social care, our social workers cannot be recommending particular services to people. They need to give advice and information to someone about how to choose a service and the important things that they need to look at. But we are agnostic beyond the point of commissioning and having services on a framework. We can't say pick that service over this service. But people do seek, word of mouth and recommendation from within their communities. And sadly, as is often the case, a negative review carries a lot further than a positive one. And then on to the last slide. I just really wanted to focus on some of the issues and gaps and opportunities that we might have. As I've already mentioned, a lot of our information is analogue, and in many instances, it's on paper format. And that's for, I guess, a range of reasons, but not least because sometimes the large majority of the people that we're working with, so the vast majority of our client base are older people. And whilst some of those individuals will have technological devices, many don't. And in many instances, whilst people have devices, they won't necessarily be able to use them to fill in online surveys or information such as that. And in terms of the national surveys that we're mandated to do, there's a really clear instruction from NHS that we continue to do that in paper format. Our population is often hidden, and again, without wanting to go into too much detail in order to not bore colleagues on the webinar who are very familiar with social care, but for those who aren't, social care is often a hidden service. People generally think that social care comes from the NHS. So the Local Government Association did a survey back in 2017, and 72% of people believe that the services that a local authority delivers through its adult social care functions were actually provided by the NHS. People get very surprised when they're asked to pay for services, and also quite surprised when it's actually not the doctor who decides whether somebody needs to move into a residential care home or not. It's a social worker. So our services are hidden, and often the population that we work with is hidden as well. And often we're, for those people who are out with that older age group, we're talking about adults with learning disabilities, mental illness, and a number of people who are often hard to reach. So they don't necessarily have a strong voice in society. And certainly for me, I see part of our role as a local authority adult social care service as making sure that those people do have a voice, and that when we look to do things and change the way we work, we do that in a collaborative way, and we reach into those communities to seek the views, and not just the views from the usual suspects, the people who turn up for all of the consultation events, but actually how do we get out there and speak to the people who don't normally come forward and make sure that their voice is heard. I've already mentioned the universal fact that people are more likely to complain if they're unhappy than they are to compliment. Though we do get some really positive feedback from people, and that tends to be predominantly from people who have received a direct care service or hands-on care. I'll often talk about our social work services as almost a sort of a ninja service. We have social workers who go in to assess people and then come out again, and when we talk to the person about the assessment, they don't necessarily frame it as a specific event. On the one hand, that's really positive, because I don't want people to feel that a social work assessment was a really bureaucratic event where somebody came out with a tick box and went through a whole lot of questions. It should be a much more person-to-person relationship building interaction, where somebody comes out, listens to what it is that the person and their family and carers are telling us, looks at what strengths they have and how we can support them within the community, and then looks to see what we might need to augment to help that person to live a thriving life. But unfortunately, that sort of approach does sometimes mean that people have less recollection of it than they would perhaps, say, remember going to see their GP, or having an interaction with somebody in their bank or something like that. So quite often when we go back to seek people's views, we have to be very specific about, and do you remember it was so-and-so who came to see you on that day, and this was the sort of information that they talked about, and that jogs people's memories of the event. Whereas if we just ask about the assessment, quite often they're not really that familiar with the term assessment, and don't necessarily reflect on the event that occurred. So some of the opportunities, we've seen a massive shift in digital channel throughout the pandemic, and that's something that we need to maintain, whether that's been from portals, and I think again across the region we saw really quick turnaround with local authorities developing portals whereby people could either ask for help, offer to help, or request support on behalf of somebody else. And that's been, in terms of Gateshead and the sort of the wider council, a massive change. We've got a really open civic centre. If anybody's been in the civic prior to the pandemic, you'll know we've got a large cafe area downstairs, which is well used by the population. A lot of people coming into the building to undertake transactions. And obviously when that building disappeared, well, it didn't disappear, access to it disappeared, people needed to sort of, make contact with us in very different ways. And that's been successful. But what we know is a lot of people are wanting to come back to the building. So we need to continue to work with our residents and our population to make sure that those people who are able to use digital devices and digital means continue to do so, so that we can create the resource that's required and focus that on the people who don't have that form of access. And within that, in Gateshead, and again I know the wider region, a really strong focus at the minute on how we address digital inequality and digital poverty, along with all of the other inequalities that we've unfortunately seen widen throughout the pandemic. But social care, we've seen a massive shift in digital channel use as well. So, almost immediately overnight, and from the 23rd of March last year, we moved to a position of online and video conferencing, telephone conferencing, etc., to undertake assessments. And, a really strange shift for us, as it was for many other partners in the NHS and other organisations. We've had some real success with that. So we've had some particularly younger adults with learning disabilities who've told us that actually they prefer having a video consultation with their social worker. Clearly it's had positive benefits in terms of things like climate change and reducing the amount of time that's spent with people moving around a borough like Gateshead. So there's been some real positives there. And again, across the Northeast ADAS patch, we've worked together to develop some defensible decision-making documentation. And that was to be used initially during the pandemic so that we could be really clear about which scenarios we would go out and see somebody in and which scenarios we would use digital technology for. But we've all said we want to maintain this going forward so that documentation will continue to be used beyond the pandemic, because we recognise that there are still benefits in being able to undertake digital engagement with people even once our social distancing restrictions are removed. We've been able to move forward during the pandemic with the Great North Care Record. So actually, you know, that old adage that necessity is the mother of all invention, we were able, under the COPI notice, to get access to the HIE viewer for a number of local authorities, and we did that earlier than we'd intended to because of the pandemic and the restrictions that were in place. And we've also thankfully gone live with our first local authority. So Sunderland were the first local authority to connect in February of this year. And then we've got plans for Gateshead, Newcastle, Durham, North Tyneside and Hartlepool all to connect. And then hopefully our other local authorities will follow suit in due course. So being able to share our information with our NHS partners, and those NHS partners being able to see social care information is obviously going to be a huge benefit for us. So really just in sort of summary, I think our position, as I say, in local authorities often feels very different to the NHS's. We don't have the huge national infrastructure that NHSI and NHSE provides for the NHS. But we are obviously very rooted within communities and therefore very committed to seeking the views of those communities, and certainly our elected members play an influential role in that. So we're really keen to be involved in this piece of work and to see what opportunities there may be to use digital technology. You know, we do that so well in thinking about technology-enabled care and the role that assistive technology has in supporting clients. So it makes sense for us to think about how we can also use technology to better understand the experience of the people who use our service and allow us to improve our services as a result.
Thank you so much, Steph, for sharing that other side of the coin with us, I guess is the way to put it. So thinking about everything that we've heard today, we're going to move on to Mark and Kristina from CGI, who are going to talk about the patient experience research project that we've been doing and how we've been looking at other data sources to find out what patients aren't telling us.
Thanks very much, Emma. Thanks also to Tom, Annie and Steph that have set the scene really well for this conversation today. Before we go into the high-level findings of the report, which Kristina will present, I'm just going to give a bit of an overview of the context about why we kicked this project off. So for those of you that don't know me, my name's Mark Thompson. I'm a director at CGI and I'm responsible for a lot of our business in the northeast of England. And I was engaged with kicking off this healthcare cluster with Andrew and Emma in September last year. So in terms of setting the scene, at the start of the cluster, one of the things we were very keen to do was to make sure we didn't just become a talking shop. So we wanted to create our own project that really would feed out and drive towards one of the themes that were identified early on. And one of the themes identified at the start of the cluster was patient experience. At CGI, we were already lucky enough to be partnering with a local Northeast organisation called Wordnerds. We've got a few of the guys on the call here today. So between CGI, Wordnerds and Dynamo, we decided to create this cluster project about using AI to try and drive better patient outcomes. We were also lucky enough to have a number of contributing partners, that being early on the NHS Business Services Authority, the Academic Health Science Network that not only helped to shape it, but introduced us to a whole range of different people. But most importantly, it's the clinicians that have supported us throughout the period of the last few months, where Kristina and I have spent a number of evenings on Teams, getting input from people after doing 12-hour days in the hospital and alike, and we're extremely grateful for those people. We've had midwives, we've had GPs, we've had consultants from a range of different specialities, and we're truly grateful, given what's going on with the global pandemic, for them to give us their time. The other thing is we were very keen to make sure we picked 2 areas rather than trying to boil the ocean. So we picked the areas of maternity and mental health, and we did that for 2 reasons. The first one is, as a result of the global pandemic, both maternity and mental health have been hit quite hard. From a maternity point of view, we have all sorts of changes in the experience, such as birthing partners and fathers not being available to join their wives as they go through the maternal pathway. From a personal experience point of view, I have a brother-in-law that spent the birth of his child, he was sitting in an underground car park in London, which was not clearly an ideal experience for him. And from a mental health point of view, everyone knows about the huge rise in mental health issues as a result of multiple lockdowns. And the second reason was because they both are specialities that have a huge crossover between health and social care, you know, where coming out of the GP surgery or the trust, there's a handover into the social care aspects. If we just flick onto the next slide, what we then wanted to do here is, just from an illustrative point of view, put in place a patient journey. So, you know, a typical pathway, although everything's not the same, would be someone develops symptoms, they have a medical diagnosis, they get treatment, and at the end they try to recover. And you'll see there, we've got the feedback survey in this pathway as well. And it's at this particular point in this pathway, but it's just for illustrative. At some point during that journey, someone will be asked to provide feedback. Now that could be through a GP patient survey, friends and family tests, maternal voices, speciality specific surveys, or the National Care Quality Commission surveys that go on. They tend to be very structured by nature. And what we're really looking for is to try and get to some of the unstructured text. Now, some of them do have that, but a lot of them don't. And what we want to try and get to is that real underlying emotion and feeling that you get from where people talk about things from an unstructured text. Now, we do know that across the entire pathway, that unstructured text does exist, all the way from someone developing symptoms through to their recovery. And that can take place in many different forms. In existing health and social care data sources, whether that's clinical databases, GP systems, you know, System 1, EMIS, trust systems, such as the systems where everyone's logging the patient data. It can be in public domains. So rightly or wrongly, people are writing about things in Facebook, Twitter, Mumsnet, Google. And then finally, there's also a number of existing non-digital data sources in health and social care, such as calls that come through on 111 or paper-based data. And given where technology is nowadays, it's not hard for us to actually use the latest technology to digitize that data and then maybe to have a look at, on an aggregated level, what that data is telling us. So that's really what we're trying to do with this project, to try and find out if we can analyze en masse unstructured text and drive towards better patient outcomes. And on that, I'll hand over to Kristina, who's going to talk you through the highlights of the project that we ran.
Thank you, Mark, indeed, for this great introduction. And hello, everybody. My name is Kristina. I am part of our digital advisory team at CGI, and I have been working together with Mark and the team on the patient experience project, looking at the insights around the maternity and mental health. And today I'm just going to give you a quick snapshot overview in terms of some of the high-level findings from our research, and I hope you find it interesting. So what have we done actually? So we aggregated a lot of data. First of all, as Mark alluded to, we used public sources. We used Mumsnet and Twitter. We then applied AI and linguistics technology from Wordnerds to understand what are the key trends and emerging insights around maternity and mental health. And we are currently in the process of analyzing and finalizing our findings, which are going to be summarized in a report which we are looking to publish in March. Throughout the process, we were very fortunate to be able to work with a number of clinicians and physicians who helped us guide through the process and highlighted some interesting nuggets to look at. So we are very grateful for their inputs, as Mark said as well. Now, just moving on and having, let's have a look at the type of data that we got. So we had over 1 million data points to analyze. The biggest contributor to maternity topic was Mumsnet, whereas for mental health it was Twitter. And it's probably not surprising to see such a breakdown. We very much focused on the negative sentiment in our research because this is where we can identify some things that are not perhaps are not working as good as they should, and therefore these are the opportunities where we could drive certain improvements and really kind of bring to life the insights that we are seeing. Looking at the quick regional breakdown here, we can see that Northeast was the 5th biggest contributor to our data set, and it was indeed one of the happier data contributors in our data breakdown. Not surprisingly so. People in the North are generally a lot happier compared to other regions in the UK, but hopefully this just gives you a bit of a breakdown and insight in terms of the kind of data we are seeing. Just a quick overview and a highlight from our research. Indeed, the graph over here on the left-hand side it gives you a kind of sense of the sort of insight we can see from the data. And you can see a big reaction here following the announcements from Public Health England and Royal College of Obstetricians. People started discussing their announcements in the press on Twitter and Mumsnet. And on the right hand side you can see some of the emerging themes, what exactly people were talking about, and it's mainly to do the safety of vaccines for pregnant women and the kind of information provided around that, and we'll come back to that in a little moment. But this is really just to give you a high level view of some insights that we are seeing. And now, whilst we don't have enough time today to really dive into every insight and every detail of our research, we wanted to highlight some interesting findings from what we found so far, and just share a couple of snippets with yourselves, but more detail will be available in our report when it comes out next month. So when it comes to maternity, some of the emerging themes are around the medication, COVID, administration within the maternity specialty, and some of the mental health challenges. Indeed, something that we found quite interesting was patients mentioned the absence of the birthing partners during pregnancy, and we know that it's not necessarily the case across every trust, but we know that some trusts had challenges around that, and during COVID, pregnant women found it particularly challenging not being able to have their partners right by their side during what some would regard, one of the most life-changing events for sure. Medication was another interesting topic that cropped up in relation to maternity. Some women felt that they were over-prescribed medication. Some felt that they were a bit too quick to be prescribed medication, and potentially perhaps because they felt that doctors were just wanting to, quickly process their concerns and move on to the next patient. So that's something that came through our research as well. Different types of medication were widely discussed. Cyclizine, if I'm pronouncing it correctly, was quoted quite frequently. But also, what's perhaps concerning is that several patients reported the fact that medical notes were lost or perhaps misplaced. And it's this kind of insight that I think helps us identify the potential ways how we can improve that patient experience and drive improvements across the patient experience through a number of different trusts around the UK. Now, just to give you more flavour around the insight that we got, this is a real example, this is a real comment from a real patient that we had in our data set. So something very positive. Staff was, as you can see over here, staff was mentioned positively quite a lot, 75% over there. The orange /red color represents negative sentiment associated with staff. but overarchingly it was very positive. And you can see in this example that a woman that delivered twins in an emergency situation felt that staff were fantastic because they were relaxed despite the emergency situation. And this just goes to illustrate how important the staff outlook is during such delicate moments in people's lives. We spoke about the vaccinations and pregnancies, and again, quite a mixed bag of feelings when it comes to vaccines and pregnancies. And predominantly, the negative sentiment was because there was a lack of information available, or indeed the information was not about testing on pregnant women, which obviously caused some concern around the vaccines for pregnant women, indeed, and their safety. So, but this is just a quick snapshot indeed around maternity, and there's a lot more information that we are providing in the report. And we also wanted to share with you just a couple of insights around mental health. So similar themes emerging across mental health: staff engagement, medication, access to services, and lack of funding for mental health. Probably not surprisingly so, patients really felt the lack of funding and treatment available to them during the COVID period. And you can see over here, people mentioning the challenges they faced when they tried to access mental health treatment and support. Medication, again, is a big topic when it comes to mental health. People specifically spoke a lot about sertraline, which appears to be one of the most commonly prescribed drugs. But most importantly, perhaps, people were discussing different dosages, different types of drugs that they use for their mental health problems. We were talking about side effects, but also very much sharing, you know, the treatment and what sort of prescriptions they were having, which is potentially quite alarming, given that people are potentially attempting to self-medicate and use the advice they find on public forums, as opposed to take the advice from properly trained professionals, medical professionals, that is. Mental health issues for children was another topic that's cropped up. Quite a few mothers were expressing how concerned they were around their children's mental health and what impact lockdown had on the children, so, which we found very interesting. Perhaps not really surprising, but certainly certainly very informative and relevant for where we are in this particular time. Now, looking at some specific comments, of course, we can't go into great lengths at looking at every single comment that we found, but you can see that when people got therapy to help with their mental health challenges, it was received generally very positively. A wide range of therapies were mentioned in relation to mental health, from cognitive therapy to talking therapy and so on and so forth. And I think it is fair to conclude that therapy was quite helpful and well received amongst the patients that we had in our data. However, on a flip side, quite a few people noted the lack of access to mental health treatment during lockdown in particular. And the comment just at the bottom of the slide is also very interesting in telling. People with mental health challenges tend to have a lesser feeling of self-worth, and they're less confident perhaps. And this comment just illustrates how that sense of self-worth is exacerbated by the way by the kind of treatment they received, or the lack of treatment they received And because they couldn't get access to treatment, they almost felt that, you know, it's because they're just not worth that treatment. So it's interesting to just see, you know, the kinds of impacts access to treatment or the lack of it can have on people and their well-being indeed. And we know that it's not necessarily the case, that it's nothing to do with individuals and so on and so forth, but that experience could potentially be quite a common experience for several patients there. So this is just a quick snapshot, of course, of our research. We don't have enough time today to go into greater detail, but we are looking to publish everything in a report which is going to come out in March. If you would like to get involved and find out a little bit more about the research and perhaps help us shape it and contribute towards it, please get in touch. You can scan the QR code here as well and drop me a line, and I would very much welcome a conversation with yourselves, and would like to have feedback and inputs even before it gets published. So next steps. So we had a quick look at the research that we did on maternity and mental health, and we did that research using public sources, looking at the data from Mumsnet and Twitter. But unstructured data is all around us indeed. And these are just some additional use cases that we have identified so far through the conversations with the various clinicians and people in our healthcare networks. So think about what sort of insight we could get and how we could action that insight if we were to able to understand doctors' notes, you know, the notes that are sitting in our system one, for example. Medication side effects. Could we understand the common side effects and be quicker at analyzing what are the most common side effects across drugs if we applied this the same technology that we used for our research here. Staff support going forwards is also going to be really important going forwards. The pandemic had a great impact on medical staff, on NHS around the UK, and we've seen lots of quite disconcerting stories being shared all around. There are some support groups we are aware of, for example, on Facebook. Could we analyze those comments and what people are saying on those groups to understand how we might help support the staff during the transition period, during the post-pandemic period, and so on? And finally, could we apply the same technology perhaps on social care notes? We keep track of all sorts of care provision related activities, and could we really apply this technology to understand what works, what doesn't work, what else we might be able to consider when it comes to social care provision, and so on. So we are very much keen to hear your views, and we are really interested in understanding how this technology could be applicable across other healthcare domains, and perhaps we can have a bit of a discussion now, and Emma, if you could help us, that would be super. Thank you very much, everybody.
So as Kristina says, this is a question now, I guess, for all of our panel who I'd like to invite up onto screen, but also for you, the audience, and we really encourage you to join in the discussion at this point. This is your opportunity to kind of influence what happens next from here and to get some early feedback. Oh, hang on, sorry, I'm to my screen.
Mark, it's probably just worth pointing out, because we lost Kristina a little bit and I had to fill in, and we probably didn't get the bit at the beginning quite right. I guess one of the things that we really want to make people aware of is this technology did this work for us. We didn't sit and do it. What we essentially did at the beginning is we picked two specialities. We identified a number of key themes we wanted to look at, and then we taught the software what it needed to look for, and then over the period of the 2 months, it came back and told us. So that's the really interesting part that I think probably without Kristina dropping off at that point, we want to make aware of, that this really is saving lots and lots of time and effort to get that consolidate all of these different data sets?
Yeah, sure. Yeah, really good point. So I guess the big question is, and I guess I would like to go back to kind of Annie and Steph in the first instance on this, just to see, after listening to that presentation and the findings, what are the opportunities to see this kind of technology across health and social care settings, especially thinking about Steph, a paper-based experience, but also Annie, I know a lot of what you do is on paper at the moment. What are the changes it could bring about, and also starting to think more widely than that, as Mark's touched upon, how can we use this tech in other areas to drive better patient outcomes? What are the changes it could bring about? What are the other data sources we can apply it to? And I guess, how can we take it wider than just our project and take it nationally? So yeah, if Steph and Annie would like to come in first, that would be great. And then I'd love to open it up to the floor.
Thanks, Emma. Annie, do you want me to go first, or do you want to?
On you go, Steph.
Thank you. I think, as I say, one of our concerns, and apologies if people haven't seen, there's been some conversations going, some in the chat and some in the Q&A. What I've said in the Q&A, and just really probably to make it clear, is I think from a professional perspective, we are already within social care quite data enabled. So adult social care and children's social care moved away from paper-based records quite a long time ago. And that's probably one of the few areas where we were slightly ahead of the NHS on that. So, we've had case record management systems across social care for, well, since the kind of the late noughties, really. But where we still do a lot of work on paper is in direct care. So it's a mixed bag, within our care providers. Some of them do have digital sort of recording systems, but others still rely very heavily on, people going into somebody's house, making a note on a piece of paper and coming out again. So there's definitely some opportunities there to think about how we, improve the use of digital technology. I mean, we're just looking at something in Gateshead about giving, we've got smartphones with all of our reablement workers, but actually giving them mini iPads and getting them to capture information on the go when they're out in people's houses. It's an opportunity. We're replacing our case management system, so we're hoping we'll have an app that they'll be able to input into, because, excuse me, for some of our direct care workers, the use of technology is a challenge in itself for them. They're not that familiar with using technology outside of, perhaps social media like Facebook and, doing sort of orders online, etc. They've not used technology at work, so that's another step and a potential barrier for them. So it feels like a really interesting area and something I definitely want to have further conversations about. I've talked to colleagues from Wordnerds in the past about this. It's just how do we make that next step, I think is the question for me. So I want to keep the conversation going. And it's worth recognising, obviously, that the community that we work with is changing. So, 10 years ago, we probably got very few emails from people. That's changed massively. So whilst we still have largely paper-based interactions with some of our clients, we do have a lot more people now who contact us via email. So it will change over time. I'm sorry if I haven't answered the question, Emma, and just waffled.
No, that's great. And also worth saying that this is really early stage in the project as well. So it's all about what happens next. Annie, you had your hand up. Did you want to come in there?
Yeah, a couple of points. So, because I think there's lots of opportunities. I have a really strong sense, and I don't know if I just think in decades because I got my job in 2009. But I think we are about to embark on a new decade for patient experience that is quite different from where we've been in the last 10 years. And I think technology is enabling us to do that in a different way and source information much easier and much quicker than we've ever been able to do that before. I think some of the exciting work around COVID and the development of virtual appointments, etc. I think we've still got some learning to do around that, about which groups that experience has been a really positive one, and which groups it hasn't. And there's some really rich learning around mental health and all of that I think is particularly welcome. I think understanding patient experience of a virtual a consultation as well as staff experience in that is critical, because clinicians are being asked to manage clinical risk in a very, very different way than they've been able to do historically. And we have to get our heads around all of that and really understand that. And I think there's a current gratitude bias in some of the data through COVID, where the NHS, although we've seen that falling off, but the NHS has gone through a sort of a heroic status at the start of the pandemic in the eyes of the population. And I think that makes people very reluctant to sometimes criticize or provide fault with some of their care, because they just think, well, the NHS is doing a great job regardless. So I think we need to stay with it and really unpack it and understand what the lasting experience of some of the technological solutions are and what that means. Other things, other real opportunities. I mean, I'm data hungry always. So I think there's a mutual benefit here, that there is an opportunity for your technology to help validate some of the learning that I think I've gleaned from all of the review of our data, however slow that is. But I review all free text comments, I read them all, I categorize them and theme them. Have I got that right? And your technology can give me a quick answer to that much quicker, but my data can also test your technology too, and help you validate the quality of your analysis, particularly sentiment analysis, and whether we're reaching a consistent answer when we look at the feedback of 500 mums through maternity services. 2,000 women gave birth in our hospitals last year. So a quick glance. So I'm very excited. And then the final opportunity, I think, is around our approach to improvement. We shouldn't do any of this measurement unless we are actually clear about what we're going to do to change it. Otherwise, we'll just frustrate people who feel that they give us feedback and there's not enough done as a result. But experience-based co-design is a lovely methodology and improvement methodology for changing services. And I think historically we may be restricted to the way that we analyze pathways in clinical care and journeys through social care services too, in our own view of the key steps along the way. Whereas I think analysis of free text allow us to hone in on touch points more readily, which is the things that are more important to individuals. So rather than talking about access, it may be that some other elements of the environment was more important to individuals. And I think the technology allows us to do that in a sensitive way, and it stops us going with an idea of what the important issues are, and rather instead doing that from a ground up way, where we actually learn what the important experiences are by analysing and mining the free text comments. So I just think there's a wealth of opportunities to do that. I hugely expect to learn masses from people like you around the table and how it makes me do my job better. But I would also encourage you to work with us in terms of what information we've got and the richness of the data that we've got, because I think that can hopefully help you too.
Yeah, definitely agree with all that, Annie. Thank you so much. I'm just really conscious of time, and I know a lot of you out there will have to go. Just to let you know, please feel free to drop off the call if you have to. However, the CGI team and I will stick around for anybody that wants to carry on the conversation. So thank you for those of you who do need to leave now. We'll send the recording and be in touch. Did anyone else on the panel want to jump in there? Maybe Kristina, Mark, where you see opportunities next? Yeah,
absolutely. I think we're being given, I mean, Annie, you've brought up a few ideas there, but even from the engagement we've had around the clinicians, some of the ideas that are being brought to the table are making us realise there's areas that we hadn't even thought of. And the problem is, at the moment, there are so many of these sources that are out there with this unstructured text. I guess what we're trying to do is just to make sure that we prioritize the right areas where it's going to lead to the best outcomes. The bit that you said that everything has to, you're doing it for improvement purposes. We're not in the interest here of just creating lots of pretty graphs and reports that says, here's some findings. If I use the specific example, and we were talking to the LMS, is it the LMS? That's right, isn't it, Kristina? The LMS around maternity, the group around maternity that the Academic Health Science Network put us in touch with. And one of the things they were really keen to point out is, what would be great is using the vaccine within pregnancy as an example, how can you actually use that as one example to say, right, we know people are seeking information that is not available. How can we use tech to immediately react to that and make sure that within the period of a day or 2 days or whatever it is, we're getting the counter message out there so that people start to become more confident in the information that they're getting. And that's just one example, but that's really, to me, the most important point. How do you drive better patient outcomes? And then the second thing from the LMS they brought forward, which is a problem that we have all the time in technology, is how do we engage with those people that aren't digital now? And it's a common issue that we have that we need to engage with. So, simple things like trying to use some of the latest technology to scan paper records, then we can get their voice, but how do we actually engage with them? Because they're not on digital channels. What we put on digital channels aren't going to help. And I don't have the answer to that. I don't think anyone has the answer to that yet, unfortunately.
Thanks, Mark. Tom, Kristina, any last thoughts?
Well, I was just going to add and say it's been a very insightful event indeed. And, when it comes to, yes, there's a lot of data, there's a lot of insights that we can utilize. And I guess in terms of coming up with how do we solve those big problems, it's very important to engage various stakeholders, and it is part of the challenge, I think, in solving some of these problems, because they are so multifaceted and require involvement from various parties. But and that's why we are opening up this conversation and sharing our challenges and our insights to create that ecosystem of people that are really keen to help solve some of these problems that we are seeing. So yeah, just a couple of thoughts there.
Thank you, that's great. I haven't got anybody who is asking to come up on the screen, but what I can certainly do is when we send this recording round, see if we can gather some feedback from participants then. I'm realising that we've run over a little bit and everybody is probably desperate for a cup of tea or the toilet. So on that note, I think I will close today's session. Thank you so much to all of our speakers. You've been absolutely fantastic. Amazing work going on, and thank you to our audience, and we'll be in touch again and see you all soon. Thank you.
Thanks, Emma.
Thank you. Bye-bye.